Wonderful. Well, thank you very much, Vicky, for inviting me here and inviting us here as an organisation to talk to you. And I kind of also want to say thank you as well to the Aplastic Anemia Trust for kind of the work you've done this month to help us raise awareness of sepsis within your communities, and for India, who very recently shared her own experience of sepsis. It's very brave for someone to share their own experience and you know, to be quite vulnerable. So really, you know, huge thanks to India for doing that. And today I'm here to kind of obviously talk to you about sepsis, but also go have a little bit of a deeper dive really into actually what sepsis is, who is affected by sepsis, how sepsis is diagnosed, how sepsis is treated, and also what is often an elephant in the room is actually what happens to those people when they've had sepsis and how they might feel in the days, weeks, and months afterwards. So, good place to start. So you know who's talking to you is me. So I'm a registered nurse. I worked in the NHS for about 15 years before joining the charity in 2018. I've got a background predominantly in intensive care, but also spend a bit of time in acute medicine as well. So I've looked after lots of patients in my clinical practice with sepsis. And now part of my role for the charity is, amongst other things, is to help support those who have been affected by sepsis. And I'll talk a little bit more specifically about that later on. And as an organisation, we were founded in 2012 by NHS intensive care consultant, Dr. Ron Daniels. We're a national charity, and our mission really is to seek to save lives from sepsis and improve outcomes for survivors. And we aim to do that in a few different ways. We instigate political change, we educate healthcare professionals, we raise public awareness, and then we provide support for those affected. And I think a first thing to touch upon really is the burden of sepsis generally, both here in the UK and also globally. And there's been much debate, particularly in the academic circles, around actually how many people develop sepsis and how many people sadly don't survive. And the truth is, we're actually not very good at accurately recording it. But whatever way you look at it, the numbers are pretty frightening, both globally and here nationally in the UK. And in 2020, just before the COVID pandemic, the global burden of disease kind of provided a comprehensive assessment of the burden of sepsis, and it kind of demonstrated a much higher incidence that was previously expected. And it reported that sepsis affects close to 50 million people globally and causes or contributes to over 11 million deaths. That's nearly 20% of all global deaths. And yes, 40% of these are among children under the age of 5, and the burden is concentrated in low and middle income countries. But I think you'd agree that the impact is huge. And the World Health Organization recognizes that sepsis is a final common pathway to death from most infectious diseases worldwide. And that will include recent COVID-19 and Ebola pandemics as well. And here in the UK, it's likely that we see between 250 and 500,000 episodes of sepsis annually. And to help put some of those numbers into context, there are more admissions to hospital each year with sepsis than that of heart attacks, and sepsis costs the NHS more each year than asthma. Both of those conditions are far more widely known than sepsis is. And we've come a long way probably in the last 10 years. We know that the general population are a lot more aware of what sepsis is, but worryingly, a recent poll that we did, it's that, what should I do if I think I've got sepsis? And we know, as I said, the recording of sepsis is poor and inaccurate. And an NCE-POD study in 2015 suggests we probably only capture 40% of true episodes. And we know that sadly, some people don't survive. Again, to put into context, overwhelmingly more people do than don't. But sadly, some people don't survive, with an estimated 48,000 people not surviving each year. And again, relating that to other conditions, that's more than bowel, prostate, and breast cancer combined. So whatever way you cut it, sepsis is huge. And good place to start is looking at actually what sepsis is, and it's quite a small group here. So I wonder if anyone feels brave enough to share with me or with the group, actually, if you're happy, or pop it in the chat if you're not happy to share what sepsis is in a sentence. Does anyone feel confident to share? If not, don't worry, I can talk about it. If I can get the chat up. Blood poisoning, yeah, so that's a kind of common thing that people might say, blood poisoning or septicemia. Actually, those terms, so septicemia and blood poisoning, are actually redundant now, and they're outdated, and certainly from an academic literature point of view, they've been kind of redundant for quite a few years. And essentially, blood poisoning, septicemia, it's the same thing, but we're now actually using that term sepsis. So, but historically, things often take a little bit of time to kind of catch up. So often, still people are told in hospital that they've had blood poisoning or septicemia, whereas actually those terms are now really redundant and shouldn't really be used. So what is sepsis? So I think first and foremost, sepsis is complex, and certainly from a physiological sense, it's complex, and it's a syndrome really. So there's lots of things happening, and I lifted this from a recent academic paper, and it kind of highlights an interplay between more than 12 various factors. So it's not a simple thing. There's not simply just one thing happening. There's a multitude of things and systems that are happening. The immune system, the coagulation system, the kind of complement system, the gut, the neuroendocrine system, all these things are happening together. So it's looking at it as a syndrome, really. And I say from a physiological point of view, it is complex. And the current and official third international definition from 2016 defines sepsis as a life-threatening organ dysfunction due to a dysregulated host response to an infection. So breaking that down, it's life-threatening, and we know, as I said, sadly, some people don't survive. And it's when our own response to an infection causes us harm or causes organ dysfunction. So when one or more of our organs don't work as they should. And I think before looking at sepsis, I think it's always helpful to remind ourselves of what's involved when we have an infection. And first and foremost, it involves microorganisms. So we have billions inside and outside of our body, and these will commonly include bacteria, parasites, fungi, and viruses. And the majority of the time, these microorganisms don't do us any harm. They stay where they should, and they don't do us any harm. Common ones you might have heard of, so Staphylococcus and Streptococci bacteria, they're commonly found on the skin or in our mouths, and on the majority of people, and they don't do us any harm. So they're part of a normal flora that's found on many people's skin and in their mouth. And as I say, they stay where they are, then they don't do us any harm. And some are good for us, but as we know, some are bad for us. And we get an infection when those microorganisms get to where they shouldn't, or when they multiply to cause level of harm. And I think it's important to note as well that not all infections need antibiotics. So viral infections don't need antibiotics, and some infections in the general population will get better on their own. So we sometimes, again, in the general population, might have an infection, and we might not be symptomatic of that infection. So in our immune system, our body will be doing what it should be doing, and we won't necessarily get symptomatic or become unwell. And as we know, those with aplastic anemia, and you're very much experts of your own condition, the bone marrow fails to produce enough red blood cells, white blood cells, and platelets. And it's that lack of blood cells that will affect the immune system and will potentially make people more vulnerable to infection. And our immune system, as I'm sure you know, is made up of a kind of network of cells, tissues, and organs, and involve the spleen, white blood cells, the lymphatic system, and our skin. Our skin is a huge part of our immune system. And there are two types of white blood cells. So we have neutrophils, which mostly help us fight bacteria, and then we have lymphocytes, which will mostly help us fight viruses. And there's no agreed definition really of neutropenia. There's kind of in the academic literature, and normal blood ranges will vary between often hospitals, but the most common neutropenic ranges are there. And as we know, neutropenia is a symptom of aplastic anemia, and it's a medical term that's used to simply describe what a low neutrophil count. I think we consider what's happening here when we're talking about our immune system, when we're talking about infection. Consider what's happening here. And in terms of a normal immune response, and as I say, I know for some of you, this response may be slightly different, but I think, again, it's important to understand what's happening when we have sepsis, what's happening in this response here. So when we have an injury, the body will sense that injury and blood flow will increase to that area. We might get redness, pain, and swelling. And that swelling will bring in kind of more good stuff like our white cells and things that will help the blood clot. So it's our body's own response of doing what it should be doing. The blood vessels will dilate, vasodilate, or become wider, which will help that process along. And as the damage is not just to the inside the blood vessels become leaky. So think of it like a sieve, which will allow some of that good stuff out, and that again will cause swelling. And then we get pain, and that's to prevent us from injuring it again really. So again, think about what's happening during this injury, during this normal response. And the majority of people, when they're unwell, will feel unwell and experience symptoms due to the immune response and not necessarily the infection itself. So again, when we feel unwell, again, in the general population, when we have temperature, a runny nose, those aches and pains, a sore throat maybe, increased sputum, and that's all part of that immune response. And those symptoms are largely due to the immune response and not necessarily the infection itself. And that immune response is normally localized to the area. So thinking back to that injury, it's localized to that area. It's controlled, so everything is doing as it should do, and it's nice and regulated. For those who are neutropenic, it's often incredibly difficult to know which infections might be uncomplicated and can be managed at home, and which might be more serious and require a medical attention. And that's why certainly a high index of suspicion is incredibly important. And we'll touch a little bit more on that later. But in sepsis, this immune response that we would normally get becomes systemic, so affect the whole body, and it becomes overwhelming. So instead of being localized, it will affect the whole body. Instead of being controlled, it's now uncontrolled. And instead of being regulated, it's now dysregulated. And as I say, lots of immune chemicals and mediators are released into the bloodstream, which triggers a kind of series of reactions and will cause systemic inflammation. And we get vasodilation, so those blood vessels become bigger. We get those leaky blood vessels, and that will lead to then often a dangerous drop in blood pressure, and that will then change how the blood and therefore oxygen is distributed around the body. So all of our organs, all of our tissues, cells, tissues and organs rely upon a blood pressure, rely upon a good blood pressure. When that is affected by that process of this systemic inflammation, then the way our cells, our tissues and our organs function will start to change. And that's when, again, we might become more symptomatic. And we know if left untreated, that can lead to shock, multi-organ failure, and death in some cases, sadly. So again, consider what's happening going back to when I have a normal response and everything is doing as it should be doing. And then we consider what's happening in sepsis. And I like to think of it as a kind of sepsis as a runaway train, really, of the immune system. So rather than it stopping as it should do at, the station nicely on time, it just keeps going and keeps going. And that immune response just keeps going and keeps going. And it's that response that does the damage, as I say, not necessarily the infection itself. So what can cause sepsis? Well, not every infection will cause sepsis, but almost any infection has the potential to develop into sepsis. And that will commonly include pneumonia or chest infections, urinary tract infections, abdominal infections like appendicitis or gallbladder infections, skin and soft tissue infections like cellulitis, but also viruses like the recent SARS-CoV-2 infection, viral infection that caused COVID-19. And I think it's important, firstly, to highlight that sepsis is indiscriminate. But we know there are certain groups that are at higher risk. And certainly for those on this call, those with a weakened immune system will come into that category. But also those with chronic health problems, those without a spleen, and the extremes of age are in those higher risk groups. But as I say, sepsis is indiscriminate, and it will affect those who are previously fit and healthy. And other than those risk factors, we don't fully understand why some people develop sepsis and why some don't. And we think there's likely a number of factors that are likely to play a part. So the type of bug causing the infection, may have recently, earlier this year, a strep A infection that was becoming more common. So we know if strep A becomes invasive, it can, cause, severe disease and people can be incredibly unwell. So the type of bug that's causing that infection, that bacteria, maybe it can be a contributing factor. The number of bugs, so how severe that infection is and left to grow and develop. So if you sit at home for a number of hours or number of days, which some people do, that infection can get bigger and bigger and bigger and worse, which can then sometimes lead to then a more significant immune response. And we know some individual host factors and genetics are likely to play a part as well. Some people may be more predisposed to developing sepsis. The reality is it's incredibly difficult to predict who will deteriorate in the context of an infection until that deterioration begins. And that, it'd be wonderful if we had that crystal ball and we could see who might really be at higher risk. And there's lots of research looking at points of care testing. So hopefully in the future, people might present at their GP, have a finger prick test, and they'll be able to look at particular biomarkers in the blood, which would hopefully be able to, risk stratify which individual is going to be at higher risk of deterioration and more severe disease. Unfortunately, encouraging, but unfortunately that's not used in practice now. And how can we prevent sepsis? Well, most importantly, if we prevent infection, then we can prevent sepsis. And this is from the Global Sepsis Alliance. And thankfully, some of this is less applicable to here in the UK. Thankfully, we have access to safe childbirth, and hospital-acquired infections are low as well. But the other important areas, along with preventing infection and that can help us prevent infection, are things like vaccination, good hand hygiene, and also awareness. So the awareness of what sepsis is, but also when to access help, is vital. Because we know, and evidence will tell us, the earlier we present and have access to healthcare, that will hopefully help and reduce the risk of us becoming more unwell. So defining sepsis, we've talked about what sepsis is, but again, how is it defined? And I'll show you this kind of professional narrative definition from 2016. So it's focusing on that life-threatening organ dysfunction due to the body's response to that infection. But I also think it's important to talk, particularly with your demographic of patients, to talk about neutropenic sepsis. And this is kind of this highlights a kind of general consensus of a definition. Again, there's not really agreed official definition, really. This is kind of a consensus of an agreement. And neutropenic sepsis is defined as a temperature of greater than 38 degrees, or, and I think or is very, very important to highlight, any symptoms of sepsis in someone who's neutropenic. Simply put, neutropenic sepsis is sepsis, and it's sepsis in those people who are neutropenic, and it should be treated initially identically to non-neutropenic sepsis. And I think this is more of a red flag, really, to get those who are neutropenic to a healthcare setting so they can be appropriately assessed by a healthcare professional. And I kind of highlighted the or there, really, and I'll talk a little bit more about that. But often there's an over-reliance on temperature, and sometimes that can be dangerous. Now, some of you might have heard of septic shock, just to further kind of confuse the sepsis thing. So septic shock is a subset of sepsis, which describes kind of a circulatory, cellular, and metabolic abnormalities. So simply put, septic shock is bad, and kind of think of it as a timeline. It starts with infection, it might then develop into sepsis, and then develop into septic shock. And the further we move down that timeline, sadly, the mortality rate increases, but it can, and the lines can be quite blurred, really, is between when does infection become sepsis and when does sepsis become septic shock. And I would say it's not your call, really. What I would say, certainly, if in doubt, to escalate it up. It's not your call to diagnose yourself with sepsis. I think it's having that high index of suspicion and actually thinking something's wrong here, I need to escalate this up. So we need measures in place that are going to help you and healthcare professionals to spot those who might have infection and who might be at greater risk of deterioration. And it's really a partnership that we say is important. It's a partnership between the public and healthcare professionals. So we need a public who is aware of sepsis and, importantly, at what point they should ask for help. And then we need a healthcare professional who knows what to do when someone presents with them is sick, because it's no good if we've just got a general public who's aware of everything to do with sepsis, but when they present at healthcare, then they're let down, or the healthcare professionals don't know what to do. So it's really key that we have that partnership. And our general messaging, and this is slightly different for your demographic, and we'll talk about that in a moment, but our general messaging to the public is, if you think you have an infection and you're more worried, speak to your GP or escalate up to NHS 111 and ask that question, could this be sepsis? It's not saying it is sepsis, but it's planting that seed, and it's getting often those people to think a little bit more outside the box. And certainly our messaging to healthcare professionals is to think sepsis if someone presents to them who's unwell, or in a hospital setting or clinical setting, they deteriorate or they become more unwell. It's thinking, could this be sepsis, or is sepsis a contributing factor here? And I said it's a partnership, and that's why we love to work with organisations like the Aplastic Anemia Trust to produce more focused and specific guidelines for some groups of people. And this is great that we can do this. And as I say, this kind of highlights, going back to that neutropenic sepsis definition, it's a kind of focus on maybe that temperature as a bit of a red flag, really, but or any of those signs of sepsis really is that prompt for you to contact your medical team urgently. And I think it's important. I've lifted this from the NICE guide. So NICE is the National Institute of Clinical Excellence, who kind of sets the standards of kind of gold standard care, really. And I think it's important for the public to be aware of what healthcare professionals should do, really. And if it was me, again, you're experts in your own condition, I'd kind of want to know really what's expected if I present at healthcare. So the guidance for healthcare professionals is if that individual is very unwell, then it's an emergency transfer to hospital. If they're more clinically stable, then again, it's an emergency transfer to hospital, but maybe to a local oncology or hematology unit or a medical assessment unit. And it's using that clinical judgment depending on various factors. So again, it's for you guys and for the public, it's not up to you to diagnose yourself with sepsis, but it's to having that heightened sense of awareness and that threshold, really. And I think this is essential. This is incredibly important. And I think if you take one thing from today, it's trusting your instinct, because it's usually pretty accurate, actually, in a lot of ways. But you, your family, or your carers know you better than anybody. Any healthcare professional, any doctor, any nurse, they know you, or you know yourself, and they know you're normal. So it's what is your normal baseline? What is your normal threshold? And any slight variance from that, particularly in the context of infection, it's about escalating that up and having that high index of suspicion and that low bar, that low threshold for escalating that up. And it you know, even if it's just for reassurance, you know, I think it's erring on that side of caution. Now, touched on this in terms of fever or temperature. So often there's an over-reliance on temperature and in a general population, but and I'm certainly aware that your demographic have to be a little bit more cautious, but in a general population, there is often an over-reliance on temperature. Temperature alone isn't part of a kind of diagnostic criteria to diagnose sepsis. As I said, I know neutropenic sepsis is slightly different, but fever might suggest infection, but it should be used as part of an overall picture. So, for example, if I had a fever, but other than that, I was generally okay, then it's using that to kind of try and risk stratify. Again, I know in your demographic, those goalposts might be slightly different. But also on the other side, and more importantly, if I felt horrendous and there was lots of other things going on, but my temperature was okay, and I then, you know, use that to reassure myself that everything was fine, that can then sometimes be dangerous. And we know that sometimes people with neutropenic sepsis may not present with fever, and actually sometimes might present with hypothermia, so a low temperature. And evidence will suggest that actually those people with lower temperature can be more sick, because it can be a kind of a sign of shock. So the body's kind of going into shock. And we know that some medications, so antipyretics like paracetamol, can reduce the temperature, and also other medications like corticosteroids may mask an elevated temperature. So I think the focus is, yes, using it as a general kind of thing to try and gauge, do I have an infection? But it's just not that over-reliance on temperature. Another important point, like trusting your instinct, is being empowered, you know, as empowered as you can be for your own or a family member's care. And it is incredibly challenging, because still there is a paternalistic kind of view, I think, on doctors and healthcare professionals. I think it's getting better, hopefully, but there still is a bit of a paternalistic thing that you tell me what I need to do and I will do it. But it's feeling empowered, and you might have seen this tragic case in the news recently, and it's incredibly tragic. And it's Martha Mills. So Martha, I think she was 11, was admitted to hospital last year following an injury from falling off her bike, and her condition quickly deteriorated, and the signs of sepsis sadly were not acted upon by doctors quickly enough. And Martha's mum, Maropi, multiple times raised the alarm about sepsis to clinicians and asked for more urgent action to be taken. but was instead, I think, dismissed and given kind of false reassurance that there's nothing to worry about, everything's going to be fine. And sadly, Martha died. And Merope has campaigned, and the UK government has kind of committed to introducing a law giving patients and their families kind of the power to request a clinical review if they feel their concerns are not being listened to and are being ignored. Exactly how that's going to look, I think it's still work in progress, but I think it's just reinforcing this being empowered that if you think something's not quite right, either to yourself or a family member, it's escalating that up and it's asking that question. And some hospital trusts now in the UK will have a formal referral process for family members that they can, page or bleep a team in the hospital. And it's using that kind of family concern and going back to that, you know yourself or you know your family member better than anybody. But it can be very tricky. And part of the problem, there's no one single sign or no one single diagnostic test for sepsis. And sepsis is a medical diagnosis and it requires a full hospital assessment. And someone who is unwell with an infection should be assessed for the presence of sepsis by looking for one or more organs that are not working as they should be. And this will normally in hospital involve vital sign monitoring and blood tests as well. And it would be really easy if we had 4 different islands. So when someone presented at hospital, we could just nicely put them on whatever island that they related to, and it would just be wonderful. Unfortunately, that's not reality. And it's one big island, and there can be lots of different conditions, lots of different things all kind of mixed in between. And it's often very challenging. And it'd be wonderful if it was as easy as this. If someone presented at hospital, they had a red light shining over their head that I've got sepsis, so they could quickly start that treatment. And it's not always that easy. In reality, it's more like this, really. You've got to try and, particularly or in those early stages, it can be really challenging. And healthcare professionals need to kind of try and identify 3 things. And this is what should happen if you present as hospital. So who to screen for sepsis, so screening prompt, who to treat as sepsis, and then how we're going to treat as sepsis as well. And some of you who've had a stay in hospital or relatives, you might have come across News 2, really. And it's used in the majority of acute hospitals and pre-hospital settings now. And it's a kind of it's a system kind of that's based on a simple aggregate scoring for a variety of physiological assessments. So things like respiratory rate, oxygen saturations, blood pressure, heart rate, consciousness, and temperature. So each of those things will generate a score. And we can use it then to try and risk stratify how unwell that person is. And most organizations will recommend that healthcare professionals think sepsis or think could this be sepsis in someone who has a News 2 score of 5 or above. So again, it's quite a good gauge of how sick someone might be. So if you're, hopefully it doesn't happen, but if you're in hospital or if family members in hospital and you just want to kind of get an idea of how poorly they are, you can ask that question to the healthcare professionals looking after them. What's their News 2 score? And you're looking at as a trend, really, and you can try and use it sometimes to ascertain how poorly that person is. So what's then going to prompt us to treat for sepsis? So Red Flags, which was developed by us, is a kind of pragmatic operational bedside tool, really. And it's a kind of combination of an elements of a few things that are associated with higher risk. And we can see there's things like a low blood pressure, a very high heart rate, a very high respiratory rate, someone who needs significant oxygen. Those things which, again, those red flags that actually combined with infection and a high News score, that's going to then prompt someone to treat for sepsis. And we know that early diagnosis and treatment is key, and it won't only improve our chance of survival, but also will reduce morbidity, so what that individual might experience afterwards. And the treatment for sepsis will involve a bundle of care. So again, it's knowing what should I expect if, hopefully it doesn't happen, but if I'm admitted to hospital with sepsis, what should happen and what treatment might I have? And it will involve that bundle of care, like senior help, making sure the most appropriate qualified people are responsible for your care, giving oxygen if needed, sending off blood cultures and blood tests, giving intravenous antibiotics if we think it's a bacterial infection, giving intravenous fluids, and then continuously monitoring to signs for improvement or deterioration. And this should be delivered as quickly as possible, but for the sickest of patients, certainly always within the first hour of recognizing sepsis. So we've covered, am I okay for time, Vicky? Yeah, brilliant. So we've covered kind of what sepsis is, a little bit of a whistle stop. But I think it's now important to kind of cover actually what happens. And some of you might have had sepsis on this call, or if you're watching a recorded. And I think it's important to look at actually what happens, because overwhelmingly more people survive than don't. But for a lot of people, it can be kind of a protracted and complicated recovery. And I think particularly in some symptoms associated with aplastic anemia, there might be an exacerbation of some of those symptoms as well. For a lot of people, having sepsis is a life-changing event. And the problems that people experience are primarily a result of the underlying disease process of what's happening when we have sepsis, but also compounded by, sounds obvious, but a lot of people don't recognize it, being in hospital is bad for you. And there's lots of things that will happen in hospital that are not good for you. Most people will undergo a period of deconditioning. Some of the medications that you use in hospital aren't good for you. Most people will have an element of malnutrition when they're in hospital, sleep deprivation, some psychological trauma. So put that in a mixing pot along with then having sepsis, and it's no wonder really why some people feel the way they do when they come home. Part of the problem, there's not a one size fits all. So we can't say to everybody, right, you've all had sepsis, this is how long it's going to take you to get back up to your pre-sepsis baseline. There are contributing factors, so things like age, pre-existing health, length of hospital stay, and genetics as well are going to probably contribute. But we know that up to 40% of people suffer at least one new problem or new limitation than previously. And some of the things people experience might be obvious and think, well, yeah, it's probably going to get an element of fatigue and exacerbation of my fatigue, or going to get some joint and muscle pains, but some of them less so. Things like hair loss and skin changes, poor temperature regulation, sleep disruption, repeat infections. All these are things that often people don't necessarily put down to their sepsis, but are incredibly common. And unfortunately, I think as a society in general, we're only quite good at supporting things or supporting people, the things that we can see. A lot of the problems people experience afterwards are hidden. So therefore, people aren't validated and they're not listened to. So things like cognition, it's a really, really common problem that people experience after sepsis. Things like short-term memory problems, attention span, concentration, but you can't see it. You can't see what someone's cognitive function is. So therefore, again, people aren't validated. And it's a really, really common thing that people experience, like the psychological impacts as well. And it's worth noting, in those first few days and weeks, a lot of the things that people experience are relatively normal, and it doesn't necessarily mean that anything's wrong. It's just an expected part of the recovery, considering just how poorly people have been. And it's not just those people who go through these doors of intensive care. So there's a lot of sick people who aren't admitted to intensive care, and that's when we're getting better now at treating people on a ward-based setting. So there's a lot of people who don't go through these doors, but they've still been very, very poorly. So it's not just those people who go to intensive care who experience problems. So what makes a difference? And the evidence will kind of tell us we have three opportunities really to enhance people's recovery. Some of this you can control, some of it might be out of your control and the responsibility of the healthcare professional. So we know the pre and early hospital care. So the sooner you get treated and on the appropriate treatment, that will enhance, hopefully, as I said, improve your chance of survival, but also enhance your recovery. So you'll probably be in hospital less time, and you'll experience less kind of morbidity afterwards. Ongoing hospital care, and sadly in hospital, we're good at putting people in a bed and keeping them there, where we know early mobilization. So the quicker we can get people in their own clothes and moving, it will have a reduction in hospital admission times. And then post-hospital care. So things like information on discharge, access to appropriate follow-up and rehabilitation, and then access to other organizations like us. But you'll be surprised how amount of people who have sepsis and leave hospital and are not aware that we exist. So they kind of stumble upon us. So what do we do? So there's 3 nurses in our support team. We all have a very similar background, and we're there, always someone there Monday to Friday, 9 to 5. And I think importantly, lots of people leave with nothing and don't feel listened to or validated. So we first and foremost, we provide a listening ear and we help to validate and normalize things. We can provide some practical advice to help their recovery, provide information and resources, and importantly, give hope and encouragement to people. I think a lot of people, particularly in those early stages, are really worried, and there's lots of things happening to them that they don't know what to do. So it's just that, that hope and encouragement for people along the way. Really easy to get in touch with us. We have a helpline. You can schedule a call, or we can communicate with you via email. And we also have peer support groups. So we have some face-to-face groups around the UK. We have some Facebook groups, and then we also have Zoom peer support groups weekly as well. So it's really easy to kind of connect with us, but also with other peers as well. I think most importantly is trusting your instinct. You know yourself better than anyone, and if in doubt, escalate it up. And I know it's hard. It's really hard sometimes to question, but I think, thinking of Martha's rule and Martha Mills, and actually thinking, okay, it's really empowering yourself to ask those questions. And sepsis is complex. We could be here for a week talking about sepsis, and it's not up to you. You can if you want, but to know everything about it and to be able to diagnose yourself, that's a clinical diagnosis. But it's trusting that instinct. Thank you very much indeed. Yeah, thanks, Ross. And I can imagine it's a worrying time, and it's just feeling it as empowered as you can to actually tell someone. I can imagine it's more challenging if you're on your own, but often kind of people will sit there quietly because they don't want to make a fuss, so they don't want to kind of complain, they don't want to kind of raise an alarm, and in that time people can be deteriorating, and then it's not until actually someone sees you or you're part of that triage, you think, oh goodness, you're much more unwell than I thought you were. And maybe there was, going along that timeline, there was an opportunity that you or a loved one could have just raised that concern again. But I appreciate it is incredibly difficult in a very busy setting. It can be hard. And that is a difficult one, isn't it? And I think Ross commented on you might, as an individual, have some guidance from your kind of specialist in terms of what to do. And then going back to that NICE guidelines in terms of, if you feel unwell but you don't feel too bad, I think that may be a prompt then to escalate that up to your specialist. You may have some very clear guidance of what to do. If you're feeling more unwell, then absolutely, I think that should be a prompt for you of representing at healthcare and saying something has changed, because things can change. In at that time of presenting at healthcare, you might not have been unwell enough, if you like, to require acute admission, but 10 hours later, absolutely something might change. And it's where often problems happen is people are given false reassurance of there's nothing to worry about. But instead of saying there's nothing to worry about at the moment and some very clear safety netting of, this is what to do, X, Y, or Z, because things definitely can change. So I think it's going back to that, trusting that instinct. You know yourself better than anybody else, and it's escalating up. And if, for example, you might go through NHS 111 and you don't feel that you've been taken seriously enough, I think it's presenting at hospital in A&E, and don't think that you're going to be a burden, because I think it's, erring on that side of caution, certainly.